Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am finishing up my PGY 5-year at the University of Pittsburgh. Today we'll be continuing our discussion of pediatric CNS tumors with a discussion of ependymoma. Ependymomas are a fairly uncommon tumor, accounting for only about 6% of CNS tumors in children and only 2% in adults. They originate from the glial stem cells. These are the ependymal cells lining the ventricles. And typically when we think about ependymomas, we divide them into intracranial versus spinal ependymomas. So intracranial ependymomas tend to have their peak incidence in early childhood with a slight male predominance. The median age of diagnosis is somewhere between 3 to 5 years, and they tend to be much less common in adults. And if they do occur in adults, typically they occur in adults less than 40 years old. So intracranial ependymomas tend to occur more in children, median age 3 to 5 years. Spinal ependymomas, on the other hand, are quite rare in children, and they tend to be more common in adults with a median age of diagnosis around 30 to 40 years old. And spinal ependymomas are also associated with neurofibromatosis 2 related schwannomas. So big takeaway here is ependymomas, we typically divide them into intracranial versus spinal. Intracranial happen more in kids, spinal happen more in adults, and the ependymomas come from ependymal cells lining the ventricles. As a complete non-expert in pediatric cancers, my goal in this talk is to give a very ground-level overview of the topic of ependymoma. So similar to what we did with medulloblastoma, I'll start by going through some basic background of ependymoma, discussing kind of the pathophysiology, presentation, imaging features, and so on of ependymoma. We'll talk about how these tumors are classified as per the 2021 WHO update, and then briefly discuss the treatment paradigm and get into a couple of clinical trials that help us guide our management. Again, not going through every study under the sun that's ever been done for ependymoma, but just hitting on some highlights that can hopefully help give a basic level understanding of this tumor and hopefully get us to a point where we feel comfortable answering questions about ependymoma on board exams. So let's start with some background. So as we said earlier, ependymoma originates from glial stem cells, and most commonly it's the cells that are located in the fourth ventricle. So remember, as we said earlier, the ependymal cells that line the fourth ventricle. And as a result, in children, this is where ependymomas tend to arise, and the tumors typically are infratentorial ependymomas. So that's just the most common location. They can occur supratentorially as well. And finally, as we said earlier, in adults, we more commonly actually see spinal ependymomas. And we've talked previously, especially in our overview talk, about the natural flow of CSF. But just to review once again, remember CSF, or our cerebral spinal fluid, starts in the lateral ventricles, and then it goes to the third ventricle via the foramen of Monro. Then from the third ventricle, it enters the fourth ventricle via the cerebral aqueduct of Sylvius. And then from the fourth ventricle, it enters the subarachnoid space via the foramina of Magendie medially and the foramen of Luschka laterally. So Magendie goes medially, Luschka goes laterally, and that's how the fluid exits the fourth ventricle and enters the subarachnoid space. That flow of CSF is important to understand because anytime we have an infratentorial tumor, especially something like an ependymoma, if it blocks off the fourth ventricle, then everything upstream of that, kind of gets built up with the CSF fluid, and that leads to hydrocephalus, and oftentimes symptoms of hydrocephalus is how these patients present. So it's important to be familiar with how the CSF naturally flows through the ventricular system. That brings us to the deeper sort of pathophysiology of ependymoma. And as we said earlier, it's thought to be a glial stem cell tumor. It arises from ependymal cells that line the ventricular system. So supratentorial ependymomas can arise from radial glial cells in the subventricular zone. And about 1/3 of the time, we might see supratentorial ependymomas, but more commonly, so 2/3 of the time, ependymomas are located infratentorially or in the posterior fossa. And the cell of origin is thought to be either the ependymal central neuroepithelial cells during embryogenesis or just from malignant degeneration of mature ependymal cells. And that's a lot of detail, but just remember ependymal cells that line the ventricular system, hence the name ependymoma. And again, 2/3 of the time, these are going to be posterior fossa tumors, 1/3 of the time supratentorial in children. Usually in children, these tumors are typically going to be in contact with the fourth ventricle, and frequently they can actually extend into the subarachnoid space. In adults, on the other hand, ependymomas tend to occur in the intramedullary spinal cord, and they can occur actually anywhere along the cord, but most commonly they tend to be in either the cervical or in the thoracic spine. And these tumors are unlikely to be metastatic at presentation. This is in contrast to medulloblastoma, if you recall, where we discussed that there is a relatively high incidence of quote-unquote drop metastases into the spine. So medulloblastoma has a higher propensity for metastases within the spine. And remember, that is why we also think about doing craniospinal irradiation kind of prophylactically, even to prevent disease from recurring along the spine. Ependymomas, on the other hand, unlikely to be metastatic. And as you will see, we typically don't do any kind of prophylactic craniospinal irradiation unless they already have metastases. I won't harp too much on presentation because we've gone over this in more detail in our Pediatric CNS overview talk. But remember, symptoms of increased intracranial pressure are often how these children present. And those include symptoms like headache, nausea, ataxia, vertigo, papilledema. And in adults, obviously, it'll depend on the tumor location, but they may have some back pain related to intramedullary spinal tumor. Workup, we've also gone into further details about workup of pediatric CNS tumors in that overview talk. But remember, we always start with a full history and physical imaging. There are some nuances around the timing of imaging. So oftentimes what will happen is these patients will first get a preoperative brain MRI, and then they typically go for maximal safe resection up front. Following maximal safe resection, we try to get a postoperative brain MRI, ideally within 48 to 72 hours, to assess the extent of resection. And the reason we don't want to wait too long is because if we wait longer than 3 days, then blood products can actually mature, and that can be confused for enhancement and that can be confused for residual tumor. So that's why we try to get those postoperative brain MRIs done within 48 to 72 hours before those blood products mature and start to appear bright on the MRI. MRI of the spine, on the other hand, we try to do about 10 to 14 days after surgery, and that is because we want to avoid any artifact from the surgery that could be confounding for disease in the spine. And same thing with lumbar puncture. Oftentimes this is done also 10 to 14 days post-operatively, and that's often because these patients have elevated intracranial pressure. So we want to avoid any risk of herniation, make sure that they're healed up from surgery, and then we perform an LP, typically post-operatively, also around 10 to 14 days. There are some neurosurgical procedures that we should all probably be familiar with for managing elevated intracranial pressure. And these are things that I learned more about as I was putting this presentation together. But two of the techniques for managing elevated ICP include an endoscopic third ventriculostomy, also known as an ETV, as well as a ventriculoperitoneal shunt, which is a VP shunt. So VP shunt, I think more folks may be familiar with already, but this is a catheter that's implanted to kind of drain excess fluid, and it connects from the brain down into the peritoneum, and it just kind of drains excess fluid from the ventricular system. So it's literally a ventriculoperitoneal shunt, or a VP shunt. The other technique is known as an endoscopic third ventriculostomy, where an endoscope is actually passed into the third ventricle, and these fenestrations are created in the floor of the third ventricle, allowing the CSF to drain directly to the prepontine subarachnoid space. So instead of, needing the CSF to go into the fourth ventricle and then drain. If we have a blockage in the fourth ventricle from tumor, we instead create fenestrations in the third ventricle and allow the CSF to directly enter the subarachnoid space from there. So based on my reading, it seems that ETV, so the endoscopic third ventriculostomy, is actually preferred over the ventriculoperitoneal shunt due to lower rates of infections and complications. But for very young children, VP shunts may be preferred just due to lower rates of failure. So important to just be familiar with what these interventions are and why they're important to manage elevated intracranial pressure. I wanted to share some general imaging features of ependymoma that may be helpful in diagnosis. Posterior fossa ependymomas, as we said earlier, often spread to the subarachnoid space. And this is, through the foramen of Luschka and Magendie. They're often described as having this quote-unquote plastic appearance or almost a comparison to toothpaste. They tend to be heterogeneous masses with areas of necrosis, calcification, cystic change, and hemorrhage, so quite heterogeneous appearing. On CT head, and I've included a case example here, the tumors tend to appear hyperdense with homogeneous enhancement, and again, cysts and calcifications are quite common. On MRI brain, these tumors can appear hypo-intense on T1, and then hyper-intense on T2. And then once we administer contrast, they tend to have prominent post-contrast enhancement. So they enhance with the gadolinium for MRI. Here are some image examples of MRI for ependymoma. So again, as we said, hypo-intense on T1, so dark on T1, hyper-intense on T2, bright on T2. And then when we give the gadolinium on the T1 post-contrast, this particular example, you can see almost like this patchy linear enhancement post-gadolinium. A couple of additional MRI features I wanted to note. So these posterior fossa tumors often appear as this tongue of tumor that tracks caudally along the cervical spinal cord. And you can see a nice example of that in this image here. You can see this sort of brightness, tracking along the cervical spinal cord inferiorly. And then the other example I wanted to show is spinal ependymomas, which often occupy the central canal, and they cause this sort of symmetrical cord expansion. So on the image I have here, you can see that hyper-intense lesion kind of occupying that entire intramedullary space. In terms of the actual histologic and molecular diagnosis of ependymoma, as we will see in the modern era, there's many molecular subtypes, and those actually impact our classification. But before we had all that molecular knowledge, we purely relied on histology. And some of the classic histologic features of ependymoma are shown here. So one of them is perivascular pseudo-rosettes, and the other is what are called true ependymal rosettes. And these histologic features help us to diagnose ependymoma. But of course, molecular features help us much more, and they can also help in prognostication. So that brings us to the classification of ependymoma, where, as we will see, molecular features do play a very important role. The classification of ependymoma is based on 3 factors. So these are the anatomic site, the WHO grade, and then molecular features, which we'll talk about on the next slide. So anatomic site, you can think of it as divided into 3 sites, right? So we talked about supratentorial ependymomas, infratentorial ependymomas, also known as posterior fossa ependymomas, and then finally spinal ependymomas. So depending on whether they're supratentorial, posterior fossa, or spinal, we kind of can classify based on the site. The other factor that we use to classify is the WHO grade. So grade 1 are called subependymomas. Grade 2 are the classic or differentiated ependymomas. So these include papillary, clear cell, tannicytic, and there's also myxopapillary ependymoma. And then finally, grade 3 is anaplastic. So I just remember grade 1 is subependymoma. 1 is the lowest, sub is, under. So subependymoma is grade 1, the lowest grade. Anaplastic is the most abnormal one, so that's grade 3. And then anything else is grade 2. And then finally, the molecular features, which, as we said, we will get to. Now, I did want to make a note about some additional groups of tumors that can be confused for ependymoma, which the WHO now classifies altogether as embryonal tumors with multi-layered rosettes. So these include embryonal tumor with abundant neuropil and true rosettes. These are called ET-ANTRs, ependymoblastomas, and then meduloepithelioma. So if you hear ependymoblastoma, that's different from an ependymoma. And keep in mind that that is classified as a separate tumor, which is part of the ETMR group, the embryonal tumors with multi-layered rosettes. And these are all treated as high-risk medulloblastomas. So those are kind of a different entity. So ependymoblastoma, completely different entity, treated as a high-risk medulloblastoma. The subtypes that we talked about, here are kind of true ependymomas, and they are managed differently. So bringing us back to how we classify ependymoma, remember we said the classification is based on 3 factors. So the location, the WHO grade, and then also the molecular features. So there's a nice table in the WHO 2021 paper on classification of ependymomas that lists out the different molecular subtypes of ependymoma. And many of them are based on the location of the tumor. So you can see that the ST mutations correspond to supratentorial ependymomas. The PF molecular subtypes correspond to the posterior fossa location. And then the SP is describing the spinal location. And then those last 2, which are myxopapillary ependymoma and then subependymoma, these can occur anywhere in terms of location. So then here's a table that I tried to make based on those various subtypes and kind of pull out some of the important features of these molecular subtypes. So supratentorial, we have 2 different molecular subtypes, so ST-ZFTA and then ST-YAP1. So ZFTA and YAP1. So ZFTA is typically associated with a poor prognosis, and YAP1 is typically associated with a better prognosis, and it's enriched in infants. But these are the 2 different supratentorial molecular subtypes. In terms of posterior fossa, there's PFA and PFB. PFA, I think A is awful. It has a poor prognosis. It tends to be in more children and infants. And then PFB is better. So it has a good prognosis, tends to be in older children. The spinal subtype, so there's SP-EPN and SP-MIC-N. So EPN is associated with NF2 mutation and MIC-N is associated with MIC-N amplification. And then finally, that brings us to the subtypes that can occur in any location. So these are the myxopapillary ependymoma and the subependymoma. The myxopapillary ependymoma is typically a favorable prognosis, usually occurs in the most caudal part of the spine. And then the subependymoma is associated with TERT mutations, mainly occurs in adults, has an excellent prognosis if it's in the spine, slightly worse if it's in the posterior fossa. So these are, in a nutshell, the different molecular subtypes that we see for ependymomas. And then here is just another image kind of showing the same information in a different way in terms of how we classify ependymomas. So we first think about where they are located, whether that's supratentorial, in the posterior fossa, or in the spine. And then from there, we know that subependymomas can happen pretty much in any location. Myxopapillary ependymomas, I think they can technically occur anywhere, but most common they occur in the most caudal part of the spine. And then the other ependymomas are kind of profiled based on their molecular subtype. So for supratentorial ependymomas, we can have either the ZFTA fusion or we can have the YAP1 fusion. For posterior fossa tumors, it's either PFA or PFB, and that is determined based on the H3K27Me3. So if there's a loss of H3K27, it's PFA. If it's retained, it's PFB. And remember, the loss is a worse prognosis, so PFA is awful, PFB is better. And then for spinal, we said there's myxopapillary ependymoma, subependymoma, and you can also have MIC-N amplified versus MIC-N non-amplified. Let's talk now about the treatment of ependymomas. The treatment of pediatric ependymomas, and remember, most commonly pediatric ependymomas are going to be intracranial, majority of the time in the posterior fossa. The standard treatment paradigm is very similar to what it is for many of the other pediatric CNS tumors, which is maximal safe resection up front, followed by tailored adjuvant treatment. And almost all of the time, these patients are going to have adjuvant radiation. The standard dose is 59.4 gray, but if the patients are less than 18 months old and have had a gross total resection, we can slightly decrease the dose to 54 gray. But otherwise, it's 59.4 gray adjuvant radiation, and it's local radiation to the tumor bed. So kind of like involved field radiation, not treating the entire posterior fossa, not treating with craniospinal irradiation unless they actually have metastatic disease in the spine. So maximal safe resection followed by local adjuvant radiotherapy. And the role of chemotherapy is more limited. We never give chemotherapy with radiation for ependymoma, but short course of chemotherapy in patients that have a subtotal resection can sometimes be considered to think about converting them to then getting a gross total resection. So chemotherapy can play a role in select patients, and as we will see a lot of time, it is to try to convert someone that had a subtotal resection to getting a gross total resection. So with that baseline understanding, let's get into some more details. So starting with maximal safe resection, as we know from other disease sites as well, having a gross total resection is the goal, and the degree of resection is actually prognostic of outcome. So I have some numbers listed here. There is data from a St. Jude experience that shows the progression-free survival is about 77% for patients that have a gross total resection versus only 34% for patients that have a subtotal resection. So it's almost half as much. And you can see, the overall survival in patients for gross total versus subtotal resection is somewhere on the order of 60 to 80%, down to somewhere on the order of 25 to 45%. And same thing with progression-free survival. It goes from, around 75% to around 20 to 30%. So much lower overall survival, progression-free survival in patients that are not able to get a gross total resection. So the goal is maximal safe resection, and we know that gross total resection is the goal because this is prognostic of improved survival. After maximal safe resection is complete, we definitely need to kind of complete the workup and determine the patient's stage and risk. So MRI brain, remember we try to acquire within 48 to 72 hours of surgery. MRI spine and the lumbar puncture, we try to get within 10 to 14 days postoperatively. And then standardly, patients receive adjuvant radiation beginning about 1 month postoperatively. So the standard dose is 59.4 gray to the tumor bed. And when we get into our discussion of evidence, we'll go through some protocols and kind of talk about how they define their target volumes. But it's the postoperative tumor bed that gets 59.4 gray. For patients that are less than 18 months old and successfully have a gross total resection, a slightly lower dose of 54 gray is acceptable, but otherwise it's 59.4 gray. If patients have metastatic disease, meaning they have disease in the spine, we can treat with craniospinal irradiation, and the dose is 36 gray. But we're not standardly giving prophylactic CSI the way we do for medulloblastoma. So it's standardly radiation to the tumor bed after surgery, and we only do CSI if we're actually treating disease in the spine. And then finally, chemotherapy, as we said, is typically not given concurrently, but it can be given either pre-radiation or after radiation. And one of the considerations for chemotherapy, and there is some data for this, but we can think about giving patients that have a subtotal resection some chemotherapy to potentially convert their disease to a gross total resection, being able to, if they had a subtotal resection, maybe shrink the tumor further with chemo so that they can then be candidates for further surgery and actually get a gross total resection. So that is kind of the main situation in which chemotherapy might be considered. But otherwise, the standard is maximal safe resection and then adjuvant radiation to the tumor bed about a month later. And the dose is 59.4 gray. and it's 1.8 gray per fraction. So that ends up being 59.4 gray over 33 fractions. Just to sort of stress the role of CSI in ependymoma, there's a retrospective review, and this is a fairly old study from 1997, but it looked at 28 patients with anaplastic ependymoma, and 12 of the patients received craniospinal irradiation in addition to the primary tumor bed boost, and then 14 received focal radiation early. This study actually showed that there was no benefit to the addition of craniospinal irradiation because the primary site of failure was actually local. So that is why we typically don't add craniospinal irradiation prophylactically for ependymoma patients, because if this cancer fails, it typically occurs locally. So that leads to the question then, when do we actually consider CSI? And as we mentioned, if they have metastatic disease in the spine, so if they have positive CSF cytology, or if their MRI of the neuroaxis shows disease elsewhere in the spine, that is when we would consider CSI. And we also know that patients that are less than 3 years old have very, rough side effects related to CSI that probably compromise their quality of life worse than any benefit from the treatment. And so we typically do not ever deliver CSI to patients that are younger than 3 years old. For patients that are older than 3 years old, and if they have metastatic disease, that is when we would consider CSI for ependymoma. And if indicated, the dose is 36 gray. But keep in mind, most of the cases of ependymoma are going to be non-metastatic, and radiation is going to be local, so we only boost the tumor bed. We will wrap up our discussion of ependymoma then by discussing a couple of trials that help guide our management in this disease site. And again, there's probably many more trials that I could include in this discussion, but I'm really trying to keep this short and sweet and just go through the most salient data and really focus on the trials that actually guide what we actually do in the modern era for management of ependymoma. And keep in mind that in reality, many patients at pediatric centers of excellence are usually treated on protocol, or at least some type of institutional protocol. And so practices may vary depending on where these patients are treated. I'm going to be presenting 2 ACNS trials, which are from the Children's Oncology Group. So the first trial we're going to talk about is ACNS 0121. And just to give a little bit of background, historically, there were 2 main approaches for treating ependymoma. So for children that were younger than 3 years, the paradigm was really surgery, chemotherapy, and then radiation was delayed until the patient was a little bit older, so for another year or 2, or until the disease progressed. So that paradigm was really surgery and chemotherapy with the goal of pushing off radiation as long as possible for children less than 3 years old. For children that were 3 years or older, the paradigm was really surgery with adjuvant radiation with or without chemotherapy. So the ACNS 0121 trial really aimed to validate an aggressive surgical approach with immediate post-op radiation for all patients. And it also asked the question, can we use chemotherapy to help convert patients that have a subtotal resection to having a gross total resection? So this trial enrolled pediatric patients defined as ages 1 to 21 with non-metastatic intracranial ependymoma, and they had to be enrolled within 56 days of initial surgery. And they did allow multiple resections before enrollment. They did require an MRI brain and spine. And in the table here, I kind of have how they defined the various degrees of resection, and then also the treatment strategy that they utilized depending on the degree of resection. So GTR1 is gross total resection 1, where the patient had no microscopic disease on imaging or on pathology. So a true gross total resection where they had kind of the entire tumor was resected, negative margins, and no disease on imaging. And these patients were managed with observation if the disease was supratentorial and well differentiated, but then all other patients received adjuvant radiation. So if it was supratentorial, it was observed, but all others received radiation. The next one was GTR2. So that's gross total resection 2, where the patients did have microscopic residual tumor. So that was seen on pathology. And these patients were treated with adjuvant radiation, whether it was located supratentorially or infratentorially. NTR is a near total resection. And that means that on post-op imaging, they had residual tumor, but it measured less than or equal to 0.5 centimeters squared. So as long as it was smaller than that, it was defined as a near total resection, and the patients were treated with adjuvant radiation. And then finally, if the patients had subtotal resection, meaning they had residual tumor measuring more than 5 centimeters on post-op imaging, more than 0.5 centimeters on post-op imaging, the patients were then treated with 2 cycles of chemotherapy, followed by a second surgery if possible, and then they were treated with radiation. And the chemotherapy that they received is shown in the flow diagram up above, but they got 2 cycles. So they got cycle A consisting of vincristine, carboplatin, cyclophosphamide, and then cycle B consisting of vincristine, carboplatin, etoposide. So both cycles were vincristine-based chemotherapy, and this was for 7 weeks. And then they were reevaluated for possibly a second surgery, and then they got radiation. So once again, just to summarize, they had 4 different definitions of the degree of resection: GTR1, GTR2, NTR, and STR. So gross total resection with no microscopic disease, gross total resection with microscopic residual, near total resection defined as less than or equal to 0.5 centimeters of tumor, and then subtotal resection where they had more than 0.5 centimeters of tumor. If patients had supratentorial disease and GTR1 with no microscopic residual, they were allowed to be observed, assuming they had differentiated histology, but all others got adjuvant radiation. GTR2 and NTR directly got adjuvant radiation, but then subtotal resection, they gave 2 cycles of chemotherapy and then reevaluated for second surgery, and then they went on to get adjuvant radiation. So this is really asking for patients that get subtotal resection, can we maybe give some chemotherapy and see if we can help them get a better degree of resection? And it's also, obviously looking at patients ages 1 to 21, so we're no longer trying to delay radiation for patients that are less than 3 years old. So here I have some details on the treatment volumes, and the GTV was defined as the postoperative tumor bed plus any residual tumor. For the CTV, they added a 1 centimeter margin, and this was anatomically defined, so it did not cross anatomic barriers to spread within the brain. And then the PTV was an additional 3 to 5 millimeters on that 1 centimeter CTV expansion. So pretty straightforward in terms of how the treatment volumes were designed. And the table on the right-hand side is just for reference, but it shows some of the dose constraints that they used for the spinal cord as well as the optic chiasm. The radiation dose was typically 59.4 gray, but depending on the age, they would modify it a little bit, meaning if the patients were less than 18 months old and they had a GTR, so whether it was a GTR1 or a GTR2, microscopic residual was accepted. These patients were treated to a slightly lower dose of 54 gray because they were younger, less than 18 months old. Everyone else, regardless of the degree of resection, if they were older than 18 months, they got 59.4 gray. And even if they were younger than 18 months, if they had a near total or subtotal resection, they still got 59.4 gray. So only patients that were less than 18 months old with either a GTR1 or GTR2 resection, they got 54 gray, but otherwise it was 59.4 gray. And then we did talk about the chemotherapy already, but for patients that had subtotal resection, they went on to get 2 cycles of chemotherapy that was vincristine based over 7 weeks. And then they were reevaluated for surgery. And then whether or not they got surgery, afterwards they would get radiation. This table summarizes the results of the study. And remember, this was not a randomized study. It was just a prospective observational study. And they had their defined protocol, which we kind of went over, and they treated children as per this protocol and then kind of saw how those children did. So The columns in this table are kind of divided into the different groups that we talked about. So the first group is patients that had a GTR1 that had supratentorial and differentiated tumors. Remember, these patients were observed. And so there were 11 total patients in this arm, and their 5-year event-free survival was 61%, but their 5-year overall survival was 100%. So they had about 37% of patients that experienced local failures, but these were able to be salvaged with additional surgery and radiation. And then there were about 9% of patients that had both local and distant failures. But despite that, their 5-year overall survival was 100%. So for supratentorial differentiated tumors that had a complete gross total resection with no microscopic residual, the outcomes were very good with observation, and the salvage rates were very high if they did recur. The next column looks at the patients that were kind of on the other end of the spectrum that had a subtotal resection, so kind of the worst possible resection. And remember, on this study, these patients were managed with 2 cycles of chemotherapy, a second look evaluation of surgery, and then whether or not they got surgery, they then received adjuvant radiation. So there were 64 patients on this arm, 37% event-free survival, and 70% 5-year overall survival. So if you look across this table, this arm that had subtotal resection did the worst. And we know that degree of resection really dictates how well these patients do. And that's probably one of the most important prognostic factors. So when they had subtotal resection, they still had the lowest EFS and OS on this study. So about 39% of patients on this study were able to get a second surgery. And of those, about half, so about 50% of those patients achieved a gross total resection. And the 5-year event-free survival was significantly higher when they had surgery. So it was about 51% when they had surgery versus about only 29% when they were not able to get that second surgery. So remember, about 40% of patients in the subtotal resection arm after they got chemo were able to get a second surgery. And of those, about half of those patients achieved a gross total resection at the time of surgery. The predominant mode of failure, again, as we know for ependymoma, it's local failure, and about 46% of patients had local failure from this group. So that is kind of the arm looking at the worst possible surgery, which is subtotal resection, and then the patients got chemo. So adding some chemo did help, but again, not the best outcomes in this particular arm. And then the last 2 columns of the table look at the patients that had better degrees of resection. So that third column looks at near total resection and GTR2, which means that they had microscopic residual disease. So if they had near total resection or microscopic residual disease, they were just treated with adjuvant radiation. And if we compare to the last column, which looks at patients that had no microscopic residual, the outcomes are very similar, right? So the 5-year event-free survival was around 68 to 69% in both arms. And the 5-year overall survival was somewhere around 85% in both arms. So 5-year overall survival was 83% if they had near total or gross total resection 2 with microscopic residual. It was 88% if they had gross total resection 1, but pretty comparable, right? The 5-year EFS was around 68% in both arms. The 5-year overall survival was around 85% in both arms. Importantly, there was a significant result on molecular testing for these 2 arms because in these groups, there was a molecular marker, 1q chromosome gain, and patients that had a 1q chromosome gain were actually associated with having worse EFS, OS, and higher rates of local and distant failure. So having that 1q chromosome gain when they had gross total or near total resection was actually associated with worse prognosis with higher rates of local and distant failure. So that's an important kind of molecular marker to know. But this is a big table with a lot of different groups that were looked at and a lot of different outcomes. I think the biggest takeaways here for patients that had supratentorial differentiated tumors with gross total 1 resection, meaning no microscopic residual, outcomes were excellent with observation, and they had 100% 5-year overall survival. 37% of patients had local failure, but they were able to be salvaged with additional surgery and radiation. So supratentorial tumors that are differentiated with a complete resection, these can be observed. Everyone else gets adjuvant radiation. So for patients that have a gross total or near total resection, these patients do very, very similarly, and they have excellent 5-year overall survival and pretty great, EFS rates as well. That 1q chromosome gain is associated with worse prognosis with higher rates of failure. And then finally, the group that has a subtotal resection, degree of resection portends prognosis. So when we have less than a gross total or near total resection, when we have a subtotal resection, these patients do perform worse. And even with giving a little bit of adjuvant chemotherapy, we were able to help some of these patients out. About 40% received a second surgery. Half of those managed to get a gross total resection, but still the outcomes aren't as great, with only a 37% 5-year EFS and a 70% OS, so much lower than the rest of the arms in this study. So finally, this brings us to the conclusions from this study. So ACNS 0121, as we have said, was a prospective study looking at patient outcomes after resection for intracranial ependymoma. And we know the most important prognostic factor is the extent of surgical resection. In this study, they looked at giving children even less than 3 years old with giving them immediate postoperative radiation, whereas before we would have tried to delay the radiation. What they found is that even when we gave radiation to children right away, if they were less than 3 years old, the outcomes were similar to older children. So maybe we don't actually need to delay radiation until the children turn 3. Maybe we can deliver radiation right away. Other takeaways, the location did not seem to affect outcomes very much, so supra versus infratentorial. And molecular outcomes, we looked earlier and knew that RELA fusion positive was kind of a worse prognostic factor. But in this study, the RELA fusion positive actually did not have uniformly poor survival. Actually, 1q chromosome gain was an important molecular marker that was associated with worse prognosis and higher rates of local and distant failure. This study also introduced this idea of giving additional chemotherapy for patients that had a subtotal resection and then reevaluating them for surgery to see if they could get maybe a better extent of resection after some chemotherapy. And what they found is that with this approach, about 40% of patients were able to undergo a second surgery, and of those, about half of them had a gross total resection. And even then, their outcomes were not as great as those that had, a better degree of resection up front. So the question is there additional therapy that we should be giving these patients? And that therapy is chemotherapy, right? Should we be giving these patients some maintenance chemotherapy? And the following trial that we'll talk about, ACNS 0831, asked exactly that. So ACNS 0831 has completed accrual as of April 2023, and we do have some early results that were presented, which I'll go through at the end. But to my knowledge, we don't have a final publication from this trial just yet. But in terms of the design, it was very similar to the trial we just talked about, ACNS 0121, but now they added some maintenance chemotherapy for particular patients. And for some patients, they actually randomized them to radiation alone versus radiation with maintenance chemotherapy. So if we go through kind of the design schema, I think it helps to kind of understand how this trial was designed. So on the very right-hand side of the schema, we have our patients that have classic histology supratentorial ependymoma that had a GTR1, meaning no microscopic residual disease. They had a gross total resection, no microscopic residual, GTR1. Those patients, so classic histology, meaning differentiated supratentorial tumors, they were observed just like they were in the prior trial. So no changes there. The patients that had GTR1, GTR2, or near total resection, if they had anaplastic histology supratentorial tumors, if they had classic histology supratentorial that was either a GTR2 or a near total resection, or any grade of histology of infratentorial tumors, whether they were GTR1, 2, or near total resection, these patients were randomized to either radiation alone or radiation followed by 4 cycles of maintenance chemotherapy. And then on the very left-hand side of this diagram, we have our patients that had a subtotal resection up front. So if they had a subtotal resection, just like on the prior trial, they were still given 7 weeks of chemotherapy, so 2 cycles over 7 weeks, followed by a response evaluation. And then if they either had a complete response at that time or they were able to get a gross total or near total resection, they were randomized to either radiation followed by maintenance chemotherapy or radiation alone. And then if they had a subtotal resection at the time of that second surgery, then they didn't really have a choice. They just got radiation followed by maintenance chemotherapy. It was not a randomization anymore. It was just they all got radiation and maintenance chemotherapy. And then for patients that had disease progression, they were then treated additionally off protocol. So big takeaway here is this design was very, very similar to ACNS 0121, but now the majority of patients were being randomized to either adjuvant radiation alone or adjuvant radiation with 4 cycles of maintenance chemotherapy. And then for patients that had subtotal resection, they got chemo, and then if they still had a subtotal resection, they went on to get radiation followed by maintenance chemotherapy without a randomization. This slide just has some of the treatment details, how they define their target volumes, the radiation doses, as well as the dose constraints. And then at the bottom, you can see what agents they gave for cycles 1 to 3 versus cycles 4 of chemotherapy. I'm not going to read through this in great detail, but I will just leave it here for your reference. And in terms of results, to my knowledge, this final paper has not yet been reported. There were some early results that were reported in 2020, and this was an analysis based on data as of the end of 2019. And they performed a primary analysis based on intent to treat, but there was a degree of non-compliance, and due to a relatively high degree of non-compliance, they also conducted a secondary planned as treated analysis. And what they found in terms of event-free survival is that on the intent to treat analysis, there was no significant difference in event-free survival, whether or not patients received maintenance chemotherapy. But when they looked at the as treated analysis, and remember there was a high degree of non-compliance, so when they just looked at the patients that were treated the way that they were supposed to be treated on that arm, they actually did find a difference, and there was a significantly improved event-free survival with chemotherapy. So of course, these results I think are quite vague, and we haven't really looked at the, dividing into the different groups based on the location and the degree of resection. So I think that will definitely kind of bring more to light, and we definitely need to await kind of the manuscript publication. But for now, this is sort of what we know, and basically it tells us that adjuvant chemotherapy may benefit some patients with ependymoma. So here's my summary slide on the management of pediatric intracranial ependymoma. These patients go for maximal safe resection, and then depending on the degree of resection as well as the location of the tumor, we determine adjuvant treatment. So this treatment paradigm, as you can probably tell, is largely based on the first trial that we discussed, ACNS 0121. So supratentorial differentiated tumors that have a GTR1, meaning no microscopic residual, can be observed, but all else are treated with adjuvant radiation. And then for patients that have subtotal resection, we actually think about giving them 2 cycles of chemotherapy followed by a second surgery and then adjuvant radiation. Now, depending on how ACNS 0831 pans out, keep in mind that this may have some additions to it, and certain patients may benefit from additional maintenance chemotherapy, but this is yet to be determined. That's all I have then for ependymoma. Hopefully this was a helpful review. Again, biggest caveat is that I'm not an expert, and to actually treat these, I would definitely defer to folks that actually work at pediatric centers who regularly treat these. That's not me. But hopefully this was a good kind of textbook overview of ependymoma. We went over some key studies, and hopefully this talk kind of covered the key points that would show up for exam purposes. If I made any errors, I would love for folks to kind of put anything in the comments that needs to be clarified or corrected. I always appreciate that. But in the meantime, good luck with studying, and thank you so much for your time and attention.